So let's get going without further ado. We've got a great panel of speakers this morning, so we're delighted to welcome them all to Glasgow. But we're going to start off with one of our local colleagues, Professor John Evans, who's a professor of clinical neuropsychology here in Glasgow, and will be very well known to you. He's a big figure internationally in the neurorehabilitation scene. And John's going to start off by doing a talk on neuropsychological rehabilitation, the state of our science and practice. Thanks, John.
Thanks, Liam, and thank you so much for the invitation to be a part of this day and this session, and thank you to Digby Brown for the invitation and for putting on this event. So Liam asked me or invited me to do a talk on the sort of a bit of an overview of the state of our science and practice in relation to neuropsychological rehabilitation. So a big topic, but I'm going to try and just sort of focus on a few things that I think are important for us to understand and to bear in mind and to know about our science and how we translate that into practice. These are just some disclosures. So when we talk about neuropsychological rehabilitation or neuropsychological interventions, these are some of the things that we're thinking about. So it could be what we call psychoeducation, so that could be giving feedback or helping people to understand the consequences of their brain injury. We could be talking about cognitive remediation or rehabilitation, and I'll talk briefly about the difference between restorative approaches or compensatory approaches. Psychological therapies, behavior management, and modifications to the environment and environmental supports that facilitate everyday living. So those are the sorts of things that we think about under this umbrella term of neuropsychological interventions. So the topics that I wanted to pick up today were, I suppose, developments, the way in which our science and our practice has developed, particularly over the last few decades. I think we've got better at understanding brain injury and improving the formulation process, so our assessments and how we as teams, as interdisciplinary teams, work together to understand and help people with brain injury to understand the consequences of their injury. Our evidence base has been growing, and I'll talk through that. I think we've got better at our methodologies, so our research has got better. There's still a way to go. I'm going to briefly talk a bit about that. And then I'll touch briefly about some psychological interventions and emphasize at the end the importance of keeping in mind cultural diversity in our neuropsychological rehabilitation practice. So let me begin with formulation. So Derek Wade, who was a key figure in rehabilitation worked in Oxford, produced a really nice paper a couple of years ago. And it's his general theory of rehabilitation, so somebody who's spent many years in rehabilitation reflecting on the processes of rehabilitation. And just one part of that was great to see, because he says, the theory suggests that a formulation based on the biopsychosocial model of illness can lead to well-informed advice and well-targeted actions while avoiding wasteful activities. And what he's really just emphasizing is that it's really important in rehabilitation that we have a good understanding and that we as interdisciplinary teams can work together to bring together our understanding of the person with whom we're working. Now, many years ago, when we established the Oliver Zangwill Centre for Neuropsychological Rehabilitation down in Cambridgeshire, back in 1996, the team there worked together to try and think about how we would all do our own separate discipline assessments of the person we were working with. And so OT, speech and language therapy, physio, psychology, and so on. And we wanted a way to try and bring it all together in one place so that we as a team felt that we could understand the person that we were working with. And that was going to guide our rehabilitation interventions. So we developed this simple sort of framework. I mean, these things always look a bit complicated when you see them up on here with lots of arrows and words. But what we were trying to do is to reflect the fact that the consequences of brain injury are complex. People have a brain injury with a life before that, experiences, their background, their personality, their culture, their experience through life. as well as having the brain injury itself and the consequences that might come from that in terms of cognition, of emotion, of physical functions, and how those then impact on somebody's ability to do the things in day-to-day life that they value and want to be doing. So our task was to try to find a way to reflect that. So this is an old version, and of course, what we've been trying to do is to update it. And so it's got even more complicated. Again, you don't need to read all of this. In some ways, I put it up just to reflect the fact that, as I said, I think life after brain injury is complicated, is complex, and there are many, many factors that influence how somebody gets on in their day-to-day life. But I think actually it's perfectly possible for us to understand that complexity, and particularly if we, as different disciplines work together to bring our skills and our knowledge and our expertise and bring that together in one place. I'm a big fan of the diagrammatic sort of putting it all on one piece of paper. When we first did this back in the day, this was done on a flip chart, and the team sat around and wrote a flip chart, and then worked with the person with brain injury and their family to check out, have we got it right? Does this make sense? Is this what's happening? So I think we've got better at this sort of process, but I think we still need to get even better. So let's talk about the science and the evidence base. So in terms of what interventions, how should we approach working with people with cognitive difficulties or psychological difficulties after a brain injury to help them achieve the things they want to achieve? Well, if you just look at the term cognitive rehabilitation in the literature, you can see that actually the number of papers that use that term over the last sort of 20, 30 years has really increased dramatically. So that's a good thing. And actually, the evidence base has reached that point where people are starting to write clinical guideline documents or do systematic reviews of the literature. So gathering the literature together and looking, what can we take from that? What are the implications for practice? Some of you will be familiar with the INCOG guidelines. So they were first produced in 2014 and then updated in 2023. So the great thing about this, for me, is that we have enough of a scientific evidence base about our interventions that people feel confident in writing guidelines. And I think part of the reason that that's happened is over the years, people have gradually upped their game in terms of the research methodologies they use to try to properly evaluate things. Does this actually help? Is it helpful? Does it produce the sorts of changes that are beneficial for the person with brain injury? So we've seen an increase in sort of methodologically strong randomized controlled trials. So the RCT is the ultimate in many ways of sort of evidence base. And we can see that reflected, for example, in the number of systematic reviews of the literature relating to cognitive rehabilitation that appear in the Cochrane Library, which the Cochrane reviews gather together all that strong RCT evidence and then produce guidelines. So we've seen quite a lot of those over the years now. But actually, when you dig deeper, the number of those strong RCTs is still limited. And running a randomized controlled trial of a neuropsychological rehabilitation intervention is expensive, because they're labor-intensive, they take a long time, so they're challenging to run. And they're not also appropriate or feasible when, for example, we're evaluating a new intervention, when we're starting out and thinking about a new way of doing something. Or perhaps when there's only a small number of people with a particular condition, or actually if we're evaluating our own clinical practice. But there are alternatives. So people who know me know I'm a big fan of single-case experimental design methodology. So this is a way of doing studies with a smaller number of people, but doing methodologically strong studies. So they're not case studies, they're not just describing what we're doing. It's a way of evaluating whether or not an intervention is being useful for the person, and although we use the term single case, it's usually more than one person in these types of studies. But what this methodology is doing is bringing to us a way of getting strong evidence for the whether or not an intervention is useful for the people that we've tried it with. So I encourage you, so if you work in a team, or if you're interested in doing research, or if you're developing a new intervention, think about starting out with a single case experimental design study. Or if you're working in practice and you want to think, how do I really show that my intervention with this person is working, a single case experimental design methodology may be appropriate. And we have help. There's good help out there for planning, for conducting, analyzing, and writing up these types of studies. So we can build our evidence base. So we can actually say, look, these things work, these things don't work. You know, that's equally important to identify the things that don't work as well as the things that do work. If we have more of that evidence, then in a sense, people begin to make use of them. Those things get into those guidelines, and then we have better consistency. Because one of the problems about rehabilitation is about the potential for inconsistency across services, across teams, in Scotland, across health boards, and so on. So we want that consistency so everybody gets access to the best rehabilitation. But there's support out there for doing this. Okay, so let's then dig into, if we take cognitive rehabilitation, where is the evidence base then? What's the science telling us in relation to cognitive rehabilitation? Well, when we think about cognitive rehabilitation, we often make this distinction between restorative approaches or compensatory approaches. Sometimes we'll combine the both. But when we talk about restorative, obviously what we're talking about are an intervention that's maybe specifically designed to try and make a cognitive function, memory or planning or problem solving or language or perception, make that better in a sense. Maybe not restore it to how it was prior to the brain injury, but sort of take it in that direction. Alternatively, we could think about compensatory strategies or techniques. So here we might be talking about external aid, so using external aids to support somebody's cognitive function, to enable that person to actually function and do the things they want to do, but with the support of an external aid, or with a mental strategy. It could be a theory informed by the literature and our understanding of how cognition works, but theory-informed mental strategy training, and there are a variety of those out there. So we make this distinction, as I said, between restorative and compensatory. So when we talk about restorative, we might be talking about, for example, computerized cognitive training, so practicing exercises related to cognition. And then increasingly there are interesting and novel techniques, sort of non-invasive brain stimulation techniques, so transcranial magnetic stimulation or transcranial direct current stimulation, so TDCS, TMS, and then neurofeedback. There's lots of really interesting research going on in this area. But as clinicians, we want to know, okay, what does the evidence base say? Does this work? Is it helpful? Is it going to help the person I work with in their day-to-day life? And, well, actually, again, the literature at the moment has reached the point where people are writing systematic reviews of this literature. There's enough studies out there that people are gathering together that evidence, and these are just some examples of systematic reviews of non-invasive brain stimulation techniques from the last few years. So if we dip into these, what do they say? Well, here's an example, and quite often reviews end up with a summary like this. This narrative review highlights the promising potential of non-invasive technologies. Okay, that's good. But then others conclude, well, the results revealed that both TMS and TDCS elicit a small transdiagnostic effect on working memory. The observed effect sizes, so the effect of that intervention, was small, yet even slight cognitive improvements may facilitate daily functioning. So a bit more cautious, but still some positive. And then if we go to the Cochrane reviews, they take the strongest line in terms of evaluating the methodological quality of studies and saying, well, look, we need to be careful. We need to only accept the strongest evidence and draw our conclusions based on that. So here's one relating to TDCS for improving activities of daily living, physical and cognitive functioning. This one is in terms of people after stroke. So they conclude there's evidence of very low to moderate quality on the effectiveness of TDCS versus controls for improving activities of daily living outcomes after stroke. So, okay, so they're recognizing that the quality of the literature is probably not strong. However, even the sort of the vaguely positive results here say don't persist when they look at the strongest methodologies. And then they draw a conclusion. Evidence of low to high quality suggests there is no effect of TDCS on arm function, leg function, muscle strength, and cognitive abilities in people after stroke. So I guess what I'm highlighting here is that we're in an interesting phase where there's lots of interesting research going on, and people are writing these sorts of reviews and gathering the evidence. And if you're reading that evidence, again, you need to read it with a real sort of critical eye. Because we can see from these three different reviews that I've highlighted, we get rather different opinions. Some, yay, this is promising, that's good. Maybe we should just be doing this. Through to, it doesn't work. It just doesn't work. And so as I say, we're in an interesting phase, and I'll come on to the clinical guidelines in a moment. One of the challenges for this sort of literature, it includes computerized training and these sorts of non-invasive brain stimulation interventions. One of the problems is how you evaluate whether or not it's working. So quite a few studies will do a cognitive training and then test people on the things that they've just been trained on. Now, if you practice something, you're going to get better at it. But the problem is that doesn't necessarily mean that that generalizes to other things, and particularly to somebody's everyday life. So in these studies, we talk about a training effect, so training the specific things. So maybe you've been training working memory. And if you do tasks that are very similar to the ones you've been doing, you're probably going to get better at them. But does it transfer to other types of working memory tasks, not the ones you've actually trained on? That's where the evidence is more limited. And then we say, well, does it transfer to somebody's everyday life? Can we see that this is having a beneficial effect in their everyday life? And at the moment, that's where the problem is we have in our literature. So you can see these training effects sometimes near transfer, but most people can't yet demonstrate an effect on everyday living. And that, therefore, tends to limit, when it comes to the clinical guidelines, why, for example, in the INCOG guidelines, they looked at that literature and they make the conclusion, well, in relation to, say, for example, attention, computer-based decontextualized attention tasks for individuals with traumatic brain injury are not recommended because of lack of demonstrated impact on everyday attentional functions. The use of things like TMS and TDCS are not recommended outside the context of a research trial protocol. And we see the same specifically for memory functions as well. So that's, in a sense, I think it's a bit disappointing in one sense. So we've got these sort of technologies, we've got these sort of techniques, but at the moment, when you look hard at the literature, we can't get the evidence that they make a big difference in people's lives. There are big challenges in measuring the impact on somebody's everyday life, which is another factor. But at the moment, we're not there yet. So, but what can we do? Okay, well, actually, a lot of what we do in rehabilitation is about supporting people to manage their cognitive difficulties with external aids and with strategies, as I mentioned. So let me just pick one example. So this is a historical example. So many years ago, back in the sort of 1990s, we were using pagers to prompt people to do things. So for people with memory impairment, with difficulties remembering to do things, we used a system called Neuropage. It was brilliant. It was great. It was a very simple concept. You wore your pager, you got your prompt, you took your medication, you did the task, you did whatever you needed to do. It was a very simple idea. And we showed in a randomized controlled trial that it was really beneficial to people in terms of helping people get the things done that they intended to do, which they didn't do without. People forgot to do things. The tech, of course, has changed since 2001. So we now have this huge range of potential technologies, just which all of us have access to in everyday life. But one of the issues is the extent to which people with acquired brain injury are actually making use of the sorts of technologies that are potentially available or could be supportive. So this is a survey that we did, and it's now about 10 years old. We've done this particular survey about every 10 years for the last 20, 30 years sort of thing. So we need to do it. It's coming up to time to do it again. But when we last did this, if we looked at how many people with brain injury in our survey were, for example, making use of their mobile phone to help them to remember to do things, it was only about 38% of people. Now, I think that that's probably changed anyway for people with brain injury. But the point was, even at that point, there's a discrepancy between what people with brain injury who with memory problems who may benefit from that, even compared to the general public who people without a brain injury who are not, or who are often using their mobile phone. It's always interesting if I just ask you as an audience, could you put your hand up if you use your mobile phone to help you to remember to do things? Yeah, so that's pretty much everybody. There's always a small number. I've been asking this question for probably 20 odd years now, and it's just gradually gone up over the years. So we all use this sort of technology, but what we want to do is to make sure the technology actually works for people with cognitive difficulties. So that issue led us some years back to develop an app called Apple Tree, which we used, in a sense, we've really used as a platform for trying to understand what aspects or what features of a reminding tool need to be built into an app to ensure that somebody with cognitive difficulties can make best use of it. And so Matt Jameson, this was his PhD work, and we've done various bits of work over the years. One of the challenges you have in research, and we have these ideas, we develop a bit of tech, and we do some research. But one of the big challenges is then how do you get that? How do you make it available? How does it get out there into the world for people to use? So what we've done latterly is teamed up with this a small company called NewMind, which was formed initially by Ellis Parry and Luke Parry there at the top, on your top left there, Ellis and Luke. As you'll probably spot, they're identical twins. And Luke, I sadly had a very severe brain injury some years back. And this was one of those stories where Ellis decided he wanted to do something to help his brother. And so this company and the app that they've developed has emerged from one brother wanting to do something to help his brother. And we've been able to team up with NewMind to try and say, well, what did we learn from our Apple Tree research that could be incorporated into the NewMind app? So there are a few things about how the system of entering reminders works, and then providing what we call nudges. And this is basically where the app will every now and again just randomly nudge you and say, hey, is there anything you need to do? Or do you need to put a reminder in? So it just sort of nudges you. And we've shown in some studies that getting those nudges actually helps you to make more use of the app and to do more things you intend to do. We've also, yes, that's the nudges. So we've also worked with, we've done a study working with St George's Hospital in London and working with patients with brain injury and the staff team there as well. And from that work has emerged incorporating some other features into the app. So now it incorporates journals, so people can keep journals in the app, and also trackers. So if you're working with your team to track things like fatigue or mood or whatever over time. So you can do that. And for the clinical team, there's also a dashboard, so the clinicians can have multiple clients who they're working with, and they can see how the person is making use of the app whilst they're in the rehabilitation environment. So here, in a sense, what we're trying to do is to say, well, there's lots of technology out there, and you're going to hear some more great technology later on from Sarah. But the challenge I think we all have is demonstrating that this technology is useful and then making it available. And I think those of us who work in this field are trying hard to do both of those things. Last few things I want to say is just, in a sense, I've focused on cognitive rehabilitation, but what we also need to think about and remember is that the psychological consequences, the emotional consequences of brain injury are another important aspect of thinking about the consequences. Emotion and mood, and in a sense, well-being. I see rehabilitation very much as, in a sense, a means of enhancing or maximizing or enabling people to live the best lives that they can. So we can think about that in terms of people's well-being. And I was thinking back to, again, about sort of 20-odd years ago, we had a special issue of the journal Neuropsychological Rehabilitation on the topic of emotion. And if I look back to the papers that featured in that issue, I suppose two things come to mind. One of which is, well, we're still addressing many of these issues now. So looking at how best to treat and manage depression after brain injury, anxiety, sexual changes and sexuality after traumatic brain injury. Jenny Ponsford, who did a paper then, is still doing some great work in that area. Post-traumatic stress, management of irritability and aggression, family work, again, community integration, and then the thinking about these issues in other countries around the world. So, in a sense, the positive thing is we've done lots of work on that in that intervening 20 years, and actually we see that reflected. So, lots of different psychological therapies now have an increasing evidence base. So things like acceptance and commitment therapy, for example, much more widely used within brain injury rehabilitation. So the point I always want to make is that when we think about neuropsychological rehabilitation, we need to think about it as the careful, planned integration of cognitive, psychological, communication, and physical interventions aimed at enabling people to achieve personally relevant goals that will improve their overall well-being. That's what rehabilitation is about. And my final point is really just to emphasize that, in a sense, we need to ensure that this is accessible to everybody. So it's important to keep a keen eye on the extent to which we're thinking about aspects of cultural diversity in our neuropsychological rehabilitation work. I have a strong interest in working with colleagues around the world to develop neuropsychological rehabilitation, in a sense, in places where there has been very little rehabilitation or very little neuropsychology. So we can think about that as expanding into the world where there aren't necessarily an established services. But it's also important to think about equity of access to people who are not perhaps part of the majority culture in countries where neuropsychology and rehabilitation has previously been well established. And I think there are a number of different ways and aspects we need to think about this. We need to think about access to services and the extent to which our services and our systems and things like culture and cultural beliefs and stigma and resources impact people's access. Understanding somebody's culture and their cultural context, we need to build into that formulation process that I said, and then make use of that creative use of people's engagement with culture, religion, with background into the rehabilitation process. And as I say, we built that into the updated formulation framework. And if anyone's interested in seeing how neuropsychological rehabilitation, the sort of way that we might do it, can be translated into a lower resource setting, my colleague Jawala Narayanan wrote this book together with Anjana Xavier, who is the patient in this story, and who Anjana suffered a stroke and what's called Balint syndrome, which is a particular perceptual deficit following a stroke in the context of a COVID-19 illness. And they describe together, Anjana's written most of the book, and they describe together that rehabilitation process. And there are many aspects of thinking about how culture was involved. So, rounding up, I suppose I'm going to say, I think our science of neuropsychological rehabilitation, the practice, are maturing nicely. I think we're in a much better position now to know how we should understand and formulate the challenges of living with the consequences of brain injury or disease. I think we've got a lot more evidence to guide our practice in addressing cognitive, psychological, and behavioral difficulties. But we have a long way to go to develop our intervention evidence base and to ensure that evidence is implemented equitably in practice, both here in the UK and around the world. Thank you very much for listening.
Thank you, John. That was a very elegant introduction and a reminder of how far we've come in the last few decades. We've got time for a couple of questions if you want to stand up and someone will bring you a mic.
I enjoyed your talk very much. I'm speaking as a brain injury survivor, it says in my card, and I enjoyed your talk.
Thank you.
Can I say I've benefited from many of the things you described in your talk and valued them because I was in the other side of the country and I live in East Lothian. But can I make a comment that having found a recipe that sort of gets me through the days, if anything's taken away, it's surprising how quickly you notice a decline in your cognitive function. And it's very disappointing, to be honest. For example, not being able to go to the gym, an illness, or some kind of new psychological insult to your system really produces, I'm from a university background too, a long time ago, but really produces a sudden decline in your cognitive function, in my experience. Mm-hmm. And I wonder whether that's a common experience for survivors. Thank you.
Thanks for your comment. And I suspect it is, and it'd be interesting if people have other views on that. But again, I think what you're highlighting so clearly is when we do that, when I presented that formulation framework, the key thing that we're always emphasizing is the interacting nature of this. So it's no good just to do a test of memory on one day on one situation, because actually, depending on how you're feeling, or like you say, how you're physically feeling, your fatigue levels, your mood, your emotion, that's going to impact on your cognition, and your cognition is then going to impact on fatigue. So these things are interacting cycles, and so when we do those assessments and the formulations, that's why we have to bring it all together into one place, and that's why we as professionals need to do it together, if you like.
Okay, thanks, John. In the interest of time, we'll move on, but thanks again to John Evans, getting us off to a great start.